Today we have a training sponsored by both City Ambulance Service EMS Training Department and also the First Responder Behavioral Health Institute. My name is Bram Duffee, and I'm a paramedic and EMS instructor as well as a communications professor. So today you're going to get to learn both about physical and communication aspects that are involved with helping someone who has to be on a ventilator. Now, if you see me on the street or in a hospital, please just say hi to me. That way I know this training was some help to you. But by the end of this training, as long as you pay attention, I expect that you're going to feel comfortable with the operations of this Zoll Z ventilator. And that's going to be important because we all want to be competent for our patient. And we know there's a quiz also at the end of the video. So if you choose to take the quiz, it will make you eligible for continuing education that's offered by City Ambulance Service and also the First Responder Behavioral Health Institute. This is simultaneously. So whoever you're registered through is who you will take the quiz through. Now, first, let's just begin with a foundational question that helps us think about modern pre-hospital care. And that's part of it because we didn't always have ventilators on ambulances. So why would we want to use a mechanical ventilator? You know, we've used a bag valve mask or BVM for decades, and they're inexpensive, really simple to operate. So why do we have this complex new piece of equipment? And the answer to the question is better patient outcomes. And this is especially true in the transport and critical care environments when we're managing patients for longer periods of time. And the core reason boils down to one of the most delicate balancing acts that we have in emergency medicine that we always don't just see glaring at our face, but it's managing a patient's acid-base balance. So the problem with manual ventilation goes something like this. When you ventilate a patient, you're directly influencing their physiology. So in fact, short of administering IV sodium bicarb, the fastest way to alter a patient's pH level is just changing how they breathe. So every breath you deliver affects the amount of carbon dioxide in their blood. And as that CO2 level changes, so does their pH. So if we have too much CO2 and the patient becomes acidotic, then they're up one creek. And if they have too little, they'll go towards the alkalosis side, right? And so both conditions can have really these devastating consequences. Now, with a BVM, we have two significant variables that make it kind of difficult to maintain this balance. And one is that we do have an inconsistent tidal volume when we just use the bag valve mask. So think about squeezing a BVM. How much air are you actually pushing into the lungs? Is it 400 milliliters, 600, 800? The truth is we just don't know unless it's just measured. And the volume changes with every single compression, and it changes based on how tired you are, the size of your hands, and if you're a new provider that takes over bagging, one person might deliver 500, another person might deliver 700. And so the lack of consistency makes it impossible to know the exact tidal volume that the patient's receiving. So that's one problem. The other thing is an inconsistent rate. So in the middle of a chaotic scene or a stressful resuscitation, humans are notoriously bad at keeping an accurate count. And there's a reason our cardiac monitors and AEDs have built-in the electronics for CPR that keep us on track, especially when our internal clocks fail. And so trying to manually ventilate a patient at exactly 12 breaths per minute, one breath every 5 seconds, that's incredibly challenging. So in reality, the rate often creeps up, and this happens especially during high stress calls. And so this combination of inconsistent tidal volume and the inconsistent rate problem that can happen is what can make our CO2 levels be inconsistent. So we might be unknowingly hyperventilating our patient, blowing off too much CO2, and then that dangerously alters their pH, or we could be hypoventilating them, and that could lead to a buildup of CO2. So that's why I want to talk about this device, which is this new Zoll ZVent, because it's one of the more popular ones on the ambulance right now, and it has become a really good tool, and it's the one I have with me to talk about. It helps eliminate some of the guesswork and the problems we talked about. And this ventilator allows us to set a precise rate and a precise volume. So the specifications show that you can set a tidal volume anywhere from 50 to 2,000 milliliters, and a breath rate from 1 to 80 per minute. So those are the Y parameters that you have to work with this machine. And so you program the exact parameters that your patient needs. The machine delivers the exact rate and volume every breath on every single time. And this gives you a good control over their ventilation and, like I said, by extension, their acid-base balance. So when you manually ventilate with a BVM, especially when you squeeze a bag too hard or too fast, you can also create dangerously high pressures in the airway. When airway pressures get too high, it can overcome the resistance of the lower esophageal sphincter. And so what happens is that instead of going into the lungs, air is forced down the esophagus and into the stomach. This is where we get gastric distension, and we know that that can cause a big mess of problems, right? Because if we have that, then we have a full stomach that pushes up on the diaphragm and makes it even harder to ventilate the lungs. So it also really increases the risk of vomiting and aspiration, and even a small amount of fluid really can cause problems, especially if it comes from the stomach. So especially a patient vomiting stomachs into their unprotected airway, it's just a catastrophic event, right? So part of what's great about having a ventilator like this is that it's designed to prevent that. So it features an adjustable airway high pressure limit, and the settings are from 20 to 100, and what happens is that you can program the maximum pressure you want in the airway, and then the ventilator will never exceed that limit. So if the pressure starts to approach your setup limit, then the machine's going to stop that breath and let you know it. And so that significantly reduces the risk of gastric distension and aspiration. And so while it doesn't eliminate that risk entirely, it just adds another layer of safety that's not really possible to replicate with a BVM. So before we can effectively use any ventilator, we need to have an understanding of two different concepts. One is PEEP and the other is PIP. PEEP and PIP. So those just aren't settings on a machine. These are physiological principles that directly impact your patient's oxygenation and ventilation. And so let's get into how this works. Now, let's start with, and for many of you this may be a review, but it's a good one. So let's start with PEEP, P-E-E-P. Most people already know that that is an acronym that stands for positive end expiratory pressure, P-E-E-P, positive end expiratory pressure. But what does really that mean in practice, and what does that mean for a patient? Well, imagine that you have a healthy functioning lung, and when you inhale, your lungs fill with air, and when you exhale, they deflate. And this process happens in millions of tiny air sacs at the end of our airways called alveoli. And so those are the microscopic balloons that we think about in a healthy person. When you exhale, these alveoli don't fully collapse. They stay partially inflated. And so that's what allows for continuous gas exchange, this oxygen moving into the bloodstream and carbon dioxide moving out, that happens even between breaths. Now, consider that we have a patient that has some kind of respiratory illness like pneumonia or pulmonary edema. In these kinds of conditions, the alveoli can become unstable. And when that happens, they start to collapse. And especially can cause a problem because they collapse completely at the end of each time the person breathes out. So each exhalation, we have alveoli collapse. And this is a condition that's known as atelectasis. So when the alveoli collapse, they're not any longer participating in the gas exchange. So no matter how much oxygen you pour over them, if they're shut, they can't do their job. So you have likely seen the clinical picture that this creates. And it's something like you have a patient on a non-rebreather, and that's essentially 100% oxygen, but their O2 saturation is stuck in the low 80s, and you might even intubate them and confirm you have a perfect tube placement and great capnography waveform, but their saturations just won't budge. And so this is a classic sign of like a widespread alveolar collapse of that alveoli. The oxygen can be there, but the lungs can't use it. So in this situation, there's only two ways that we have to increase the patient's oxygen saturation. One is we can increase the amount of oxygen that we're giving, right? So that turn up the O2. The other thing that we can do is add this PEEP that we're talking about. So PEEP is a constant pressure that's applied to the airway at the end of each exhalation. Its primary job is to act as like this stent that physically holds those tiny alveoli open so they don't collapse when the patient breathes out. So by keeping them open, PEEP ensures that the gas exchange can occur continuously. And so this is something that works cumulative. So with the first breath, a certain number of the collapsed alveoli pop open and stay open because right there at that time at the end of the expiratory pressure. And then with the next breath, more alveoli are sort of recruited into this movement. And so it continues breath after breath. So it's like turning on lights in a dark stadium, one section at a time. And all of a sudden, you have the entire lung lit up where it's open and available for gas exchange. So as more alveoli are recruited over time with this PEEP being applied, you can see the patient's oxygen begin to climb. Now, we normally always start at 5 of PEEP. And a healthy, conscious person naturally maintains about 2 to 3 of PEEP on their own. And when we intubate a patient and connect them to a ventilator, we're bypassing their natural mechanisms. And so because of that, we need to compensate for that and for the dead space that's in the ET tube and the vent circuit. So starting a PEEP at 5 is standard for nearly all ventilated patients. And it's just enough to restore their normal physiological state of balance. Now, on this vent, the adjusting can set anywhere from 0 up to 30 of PEEP, and some of the higher PEEP pressures can be important to use in special cases. I know when we had COVID patients in the past, those are some of the folks that required some of the higher levels at times. So the thing is that PEEP is essential for oxygenation. At the same time, it's of course possible to have too much of a good thing. So when you apply PEEP, you're increasing the pressure inside the thoracic cavity. And this increased interthoracic pressure can compress some of the rest of what's going on in there, like the heart. And that reduces the amount of blood that can return to the heart because of those pressures. So if we think about a decrease in the preload because of those pressures is going to, of course, lead to a decrease in what the heart can put out. And so all of that we can expect can cause a drop in the patient's blood pressure. So because of this direct hemodynamic event, you have to always monitor a patient's blood pressure really close when we use PEEP, because your patient needs more PEEP to improve oxygen. When they're in that spot, we want to titrate up their PEEP slowly in small increments, like 1 or 2 at a time, while watching their oxygen saturation and their blood pressure respond, because we have to recognize that these are all systems that are interrelated, and increasing PEEP can drop blood pressure. So some takeaways are that PEEP does improve oxygen saturation by recruiting some of these collapsed alveoli and keeping them open for gas exchange. And it's a really important tool for treating folks who can't breathe, especially when they can't respond to just high levels of oxygen alone. We also have to recognize again that PEEP can decrease the patient's blood pressure, because that changes the thoracic pressures that end up reducing cardiac output. So now that we've talked about PEEP, P-E-E-P, next I want to talk about PIP, which is peak inspiratory pressure. So this is the highest level of pressure reached in the large airways during the inspiratory phase of a breath. When you're breathing in, this is the big whoosh that you get. So on this Zoll ZVent, the PIP is displayed as a digital readout so that you can see it with every breath that's delivered. And you can also see how that measures up against lung compliance. So a common argument against using a ventilator is that you lose the feel of the patient's lungs. And when bagging a patient, experienced providers can feel changes in compliance on their own. So for example, in a trauma patient, if it becomes progressively hard to squeeze the bag, then you could start to suspect something like a tension pneumothorax in that moment. But research has shown that this tactile feedback is not the most reliable thing. And by the time that you can feel a significant change in the compliance with that bag valve mask, the underlying problem is probably too far advanced. And so a subtle increase in resistance might go unnoticed for dozens of breaths. And so by the time you finally recognize it, the patient might already be hypotensive or in cardiac arrest. So this is what makes ventilators so cool, because the PIP value gives you a precise, objective numerical measurement of lung compliance with every breath. So instead of relying on this subjective feel, you have a better hard data. So for example, as a pneumothorax develops or a bronchospasm worsens, the lungs will become stiffer. And so to deliver the same volume of air, the ventilator has to generate more pressure. And you'll see the number start to climb by every breath. You can identify the trend and recognize the problem in real time. So that's one of the things that the ventilator can give you once we can understand how to monitor the PIP. And it's like having a window into the patient's condition, because a climbing PIP is a early warning sign that tells you something that, this patient's harder to ventilate. And it could be a pneumothorax, it could be a bronchospasm, it could be a mucus plug, or it could even be the patient biting on the tube. So by trending this one number, you can anticipate problems that intervene, to help intervene before things go. Now, I want to talk about some of the modes that the ventilator has. And to begin with, I am going to pull up the actual ventilator that I have, the actual ventilator I have, so that we can see the piece together. And I want to just mention that if you've not worked with this ventilator before, there are some key things to know about that we'll talk about. One is that a benefit that I've noticed is that once you have a fully charged unit, it will stay charged for a long time. So you can usually go without worry between patients as long as you keep it fully charged. The downside is that the plug, which is here, the plug for the power looks like a lot of other ventilator plugs. So I just want to caution you to make sure that you're picking up the right plug for the ventilator to make sure that it seats in there correctly and works. When we look at this ventilator, it's something that looks really simple because once we turn it on, it has a screen with hard numbers that line up directly with the pieces on the screen. And you are told right away how to set up the ventilator. And normally what we're going to do is just take how many breaths per minute, what the tidal volume is, what the oxygen percentage is, and what the PEEP is, and we're going to plug those in. And so if you're an experienced ventilator user, we know that we're just going to find those and plug them in. And I want to let you know that the one important thing about this ventilator is that when you go to make those settings change, what we do is we go on the side and click the button that allows us to line up with the selection on the screen. But once we change it with the dial to the number we want it to be, we can't just click the same indicator we had before or push in on the dial. We always have to press the check mark that is green. And that's what sets that spot in place. So you might go in honky-dory to go set up your tidal volume and your other settings, and you think, oh, I had already set this other one up, but it didn't stay in place. And the reason is because it allows you to change the setting, but it doesn't lock it in place until you tell it to with that green button. I know it sounds funny, but some ventilators just have strange qualities about them that you don't know about right away. There are lots of other great features to know about. We'll talk later at the top about how there's a light system at the top, which is green, yellow, and red, that you can see those indicators. Those indicators line up with the level of concern that an alarm is giving you. So that's also a pretty neat feature. Our unit comes in a basket that can be hung, and all of the plugs are on the same side, which is nice because when you're lining up the patient how you want to line up the patient with the ventilator and everything, you can have it all go to the same spot. Now I want to show something. This is that area that we have where everything plugs in. And you can see that what we're doing is something as simple as connecting the vent circuit into that big port that it fits into, and then connecting the other two sensor hoses into those ports. we know that the sensor hose is in the correct port because it has a color that lines up with that same one. So there's a green one that lines up with a green cable, and the other one is clear. The other thing, of course, that we have here is a big screw a receptacle where we will plug in our oxygen. And so the oxygen, of course, goes into here. The other spot that we're looking at is the AC plug area that's right here. But hopefully there won't be much need to use that once we're with a patient. This oxygen sensor can plug up so that you can also connect your oxygen to here. Some folks will have oxygen on the heart monitor connected, but then also pulse oximetry on here. Both are fine. I'm just showing these aspects off to show that this is a really simple monitor. And so when I say simple, I mean that it's one of those things that if you know some of the basics, this is a tool that's really durable and can only be messed up a few ways. And so a lot of times we think about how a patient needs to just breathe air in and out to live, right? And it's that simple. And I think that's what we teach when we teach first aid CPR classes and stuff. But the reality is that when we have a patient that's a critical care patient or someone that's really fragile, all of these things can disrupt that patient. And so we normally go into the room of the patient and write down all the drips and that the patient's on, and then write down all the vent settings that the patient is on, so that you have that for yourself as a document ready to go, so that if a pump turns off, a vent turns off, you automatically know what those are and you have those ready. So when you go in to greet your patient, that's one of the first things. But then a lot of times the patient is already on a vent tubing set of their own. And I want to caution you because sometimes the CPAP masks that the patient has are not correctly vented for the device that we have. Also, similarly, sometimes the patient's vent circuit on their machine is not exactly set up like ours. So, in the past, when there are multiple different types of ventilators out there, I want to caution you to know that patients have died because some ventilators don't have this relief valve on the vent circuit and others do. So just because the patient's being ventilated doesn't mean that the air is going out correctly as well. And so we want to use our equipment that we know goes with our ventilator every time because of that concern. We don't know if those same specs are matched up, and we don't want to take that risk. So that's all part of checking our equipment and making sure that that these things line up. The other thing I want to mention is that when we work with a ventilator, we saw that one end of this oxygen cord goes into that ventilator. And from time to time, you're going to need to change the oxygen source. And so we use a quick connect device. And that quick connect device goes into here and then simply pushes right into the sidewall of the ambulance to be able to deliver oxygen. And so it should be a fast, seamless process. But I have seen hospitals a lot of times when there are no quick device receptacles in that room that match up with ours. So we can't expect that just because our quick connect works in our ambulance wall, we can't expect that it's necessarily going to be a quick connect that's going to work in the hospital wall every time. So because of that, I want to ask you to bring an extra bottle of oxygen with you every time. Just get in a habit of just bringing it with you. And Also, please get in the habit of bringing the bag valve mask with you. So in my mind, I like to have one with me, but it's sort of a mandatory thing if you're in an elevator. I don't know about you, but I could easily get nightmares of, you know, having a power failure on a ventilator and being stuck in an elevator, right? So we want to have a bag valve mask with us as well. So I know it sounds like a lot, but we're managing a lot. We're taking care of critical care patients. So far we've talked about why does a ventilator matter? Why do we care? We've talked about the difference between PEEP and PIP, and then we've kind of looked at this ventilator. I haven't turned it on because it's really loud, like everything, of course. But when we turn it on, like most ventilators, this is going to have some different ways to deliver breaths, and they're pretty universal. But I want to go over these modes so that we can make sure to understand them. The first one is called assist control, and so AC is when in both volume and pressure evaluation that can come. So AC is one. Another one is SIMV, synchronized intermittent mandatory ventilation. So that also pushes volume and pressure. We also have CPAP, of course, and then the bilevel, often known as a BiPAP. Now, what really differentiates these different modes is how the ventilator responds when it senses the patient trying to take their own breath. So the vent we're looking at today is designed to detect a patient's inspiratory effort. So this ZVent is set up so that when the patient's diaphragm contracts, it creates a negative pressure or a sort of a suction in the circuit. And the ventilator's trigger sensitivity is this threshold that is the negative pressure, is where the negative pressure has to cross for the machine to recognize that that patient has initiated a breath. And the default setting is really sensitive, like a -2. And so if the patient generates more than just barely anything, and the machine is going to register that the patient is breathing, and it's going to respond according to what mode that we have it for. So the first mode is that AC mode. So the easiest way to understand assist control mode is to break down its name, assist and control. So the control part is where you set a minimum backup respiratory rate. So if the patient is not breathing at all, the ventilator will take full control and deliver the breaths at that rate. So for example, if you set the rate of 12 breaths per minute, then the machine's going to deliver one controlled breath every 5 seconds. So that's the control part. And the assist part works like this. If the patient initiates a breath on their own, like by triggering the machine's sensitivity, then the ventilator is going to assist them by delivering a full machine-sized breath at the volume or the pressure that we program. So in AC mode, every single breath is a machine breath. It doesn't matter who starts it. It's like the machine does it on its timed interval, or the patient who starts out that breath to make their own effort. But every breath delivered is going to be identical in size, either with that set volume or a set pressure. The main issue with the assist control lies in how the patient handles, because patients who are breathing on their own, especially if they're breathing rapidly, can maybe not be the best fit for that mode. So if a patient starts taking breaths on top of what you're already giving them with the machine, then this can cause a massive amount of CO2 that can lead to a dangerously high pH pretty quick. So because of this, AC mode is really best for folks who are heavily sedated or apneic, and not so much ideal for patients who are breathing rapidly or have like an erratic respiratory pattern. These folks are fighting the ventilator. So that's why we want to talk about some of the other modes. SIMV mode, this synchronized intermittent mandatory ventilation, it's set up so that when the patient is apneic, SIMV functions exactly like AC mode. You set up a backup rate and target volume or pressure, and that machine is going to deliver those mandatory breaths just if the patient's not breathing. But the key difference is how SIMV handles spontaneous breaths. So any breath that the patient takes above the set mandatory rate is going to be registered. So that machine recognizes and starts to synchronize its mandatory breaths with the patient's own efforts. So now we've seen AC mode focuses on delivering that pressure, that volume, that rate, no matter what. And SIMV is something that is high tech and working to support the patient's own efforts. But for any breaths that the patient's for any breaths the patient takes in between the breaths that are the mandatory breaths, that the ventilator just opens a valve and allows the patient to breathe on their own. So if we have extra breaths, it doesn't assist with those breaths the same way. And so it lets the pull of the tidal volume happen on their own. So this means that we're giving them air when they need it, and they're able to also pull air when they feel like they want air. And it allows their own mechanisms to function. So if their body feels like it needs to breathe a little bit faster to blow off some CO2, then they can do it without causing their minute volume to skyrocket. And that gives the patient more control, and it prevents this whole breath stacking that can occur in the AC mode. So for that reason, SIMV is much more reliable for a patient that is semi-conscious because of its versatility, and a lot safer because of the way that patients are sometimes managing their own respiratory drive at the same time. And so it's going to help provide a baseline of support while allowing that patient to help regulate their own CO2 levels. Now, those are the two ventilated full-on modes that we focus on. The other two have to do with CPAP and bilevel. And CPAP, continuous positive airway pressure, CPAP is continuous PEEP delivered through a mask. So we think of this continuous PEEP as like sticking your head out of a car window on a highway. You have this consistent, unyielding pressure of air. So the primary purpose of CPAP is something that you have there to improve oxygenation. It does it by recruiting those collapsed alveoli, just like we talked about with PEEP. The only two settings that you have to adjust with the CPAP mode are the PEEP level and then the oxygen percentage. So the real challenge to CPAP, this blast of air all the time, comes down to patient tolerance, because it can feel claustrophobic, it can make a patient feel uncomfortable, and that constant pressure makes it difficult to exhale, especially why we worry about this with COPD patients. And so it's why the patient coaching is really crucial. And so we do things like try to let the patient hold the mask on their face first. Let them pull it away and give it back to them. Explain that they're getting a big mask that's going to push a lot of air, and talk about how there's a strap that's going to hold it on, and you can tell them that it's okay to be frustrated, and it's good to empathize with them because it's a really scary event. So we know that there's only 2 settings for CPAP, and the big concern is that we have a patient tolerance because they have to handle this blast of air all the time. It's especially good for these patients who have pulmonary edema and congestive heart failure. But again, just like we talked about when we change these endothoracic pressures, we also can drop blood pressures. So if we give a patient if we've applied the CPAP, then we need to be doing blood pressures to closely monitor them. So we talked about PEEP, but now I want to talk about BiPAP. And this whole bi-level BiPAP thing, it's really for a specific group of patients. And so it's like these folks who meet criteria for CPAP, but at the same time don't really improve because they're so tired from breathing. So they're just too tired to pull in an adequate tidal volume on their own to breathe in air. And so because of that, you can increase the PEEP all you want, that blast of air all you want. But if they're only taking in these itty bitty breaths or not much breath at all, then they're not going to be able to effectively blow off any CO2. I have had more than one patient who is on CPAP who stopped breathing completely. And if a patient is not able to breathe on their own, then that means that they come off that and we have to start breathing for them with a bag valve mask and airway adjuncts and all of those things, right? And so these folks have to the mandatory thing is that they have to be breathing on their own to get on this machine. But once they get on this machine, we need to make sure that they are continuing to breathe, right? Because we're pushing a lot of air in. Now, this bi-level or BiPAP does everything that the CPAP does, but it adds this second higher pressure during inspiration that helps that patient take in a deeper breath. So it's like a boost, right? And so the terminology sort of changes a little bit here because we think of EPAP and IPAP when we look at this bi-level measurement. And the EPAP is the expiratory positive pressure, and the IPAP is the inspiratory positive pressure, one in, one out, right? So EPAP, this is the exact same thing as PEEP or CPAP. It's this baseline pressure that keeps the alveoli open when you're trying to exhale. So your EPAP is that alveoli, it's keeping the alveoli open on exhalation. The IPAP is the higher pressure that gets delivered when the patient starts to inhale. So remember we talked about how the ZVent is set up so that it can really detect a patient taking the smallest of efforts of breaths. And that's good that it has that capability because it means that it helps initiate that IPAP. And so this inspiratory positive pressure is this extra push that helps the patient achieve a better tidal volume. So by setting the IPAP, you're going to directly influence the patient's tidal volume, and that's going to give you control over their CO2 removal. And this is also a really crucial intervention that prevents the patient from getting too tired and really requiring intubation. So when documenting or giving a report on a patient using this mode, always refer to their IPAP and their EPAP settings. So you would say something like, this patient's on bi-level at 12/6, right? So these are usually things that happen in the moment, but we should be ready to give and receive that information so that we're clear on where the patient is at, because there are times when there's an adjustment that's made before we leave, and then the patient's nurse on report gets different information. So we want to be clear of that information and where we're at and why we're there. Now, I want to mention one of the cool safety features of this ventilator is that it has the ability to initiate and switch into this backup mode. And so the backup mode is triggered by a high priority alarm. So usually those that are related to internal problems or a patient condition that's dangerous. So when modes change, when alerts come on, you get, for a problem, you get a visual alarm and hear an audible alarm both, right? The screen's going to state that the backup mode is active, and the device is going to attempt to continue ventilating using the same settings that happened before the failure occurred. So it means that the ventilation doesn't just stop. If the device ever detects a dangerous condition like really high pressure, we know that could be like blockage or kinking of a line, or it may be a patient disconnect or air or trapping. What it does is it gives 3 consecutive breaths while in backup mode, and so automatically switches to like a pressure targeted configuration. And this is a safety mechanism to try to prevent excessive pressure from damaging the lungs. But what it's doing is it's working to show and find the problem. So here's our action. If a device enters a backup mode, our immediate action is to assess the patient. So if the ventilation isn't good enough, then we just disconnect the patient from the circuit and manually ventilate with a bag valve mask while we troubleshoot or swap the device. And some of the alarms on the ventilator are categorized by priority. So like a high priority alarm would show you that it's a high priority alarm by flashing a red light. A medium alarm would be a yellow light, and a low priority alarm would be like just a steady yellow light instead of a flashy one. So I just want to mention some of the common problems so that we can troubleshoot. And I want to start by saying that like I mentioned, we want to assess our patient first, make sure they can breathe, and that means that we're checking all of our connections, and we're checking capillary refill, skin color, level of consciousness change. Those things are all part of that. But we know that the machine, if it went into a backup mode, that means that there is a problem, and so this is what we'll think about. So 1, if we have a high pressure alarm, then that means that the pressure that's required to push that breath in has just exceeded the limit that we set. That means that what's going on is the machine's stopping that breath because it's wanting to protect the lungs, right? So if it can't push through, then we're going to recognize that we have to look for kinked tubing because that vent circuit does move, right? It could be from the patient coughing or bucking the system, like fighting the vent. It could be from a sudden pneumothorax, or it could be from a tube obstruction, like the patient bit the ET tube, or we have a mucus plug. So the immediate fix is to check for kinks, assess for pneumo, suction the airway. If the patient's biting, then we might consider additional anesthesia, depending upon what's happening with the patient. So those are all things that we can do to troubleshoot that alarm. Now, a low pressure alarm, the disconnect alarm, that means that the machine pushed a breath, but it didn't meet any resistance. And so it dropped below the baseline PEEP. And so common causes from that are a circuit disconnect. So it's probably the most common cause because that pop-off valve off the circuit can just easily come loose. And if you're behind the patient, you might notice it. Or if it comes off the ventilator and it's on the side of the ventilator on its other side, it could pop off and you not notice it. So a circuit disconnect is one thing. A cuff leak is another thing. That pilot balloon on the ET tube might have had a change. And so for air escape that happened in that area, you might be able to detect that from hearing gurgling in this area that you didn't hear before. So an immediate fix would be to follow the tubing from the machine to the patient and reconnect any loose segments. And if that cuff is blown, then we're going to reinflate it. Now, the other concern would be an apnea alarm. An apnea alarm means that a patient hasn't taken a breath for a set period of time, usually about 20 seconds. So that means that they haven't detected the patient to do it. And so this is usually something that happens in CPAP mode or in a mode when that machine is expecting the patient to give some effort to breathe there, right? So the fix is that, well, if the patient stops breathing in CPAP, they need to be ventilated, like I mentioned. So we can either breathe for them or work to verify if the patient is breathing or not. So in general, our summary for troubleshooting is that we look at the patient because these alarms are noise. And the noise is something that we can easily become distracted about to the point where we become numb to it. So the patient is always the priority. Are they blue? Is their chest rising? Do we have an oxygen saturation? We look at the screen to be able to see the specific alarm message so that we know how to fix it immediately. And then most of us are familiar with the mnemonic DOPE, and it's a good time to mention it now. So for all troubleshooting related to ventilators, since I've been practicing forever, the DOPE mnemonic, DOPE, think about it like this. You are in a situation where alarms are going off, you don't know what's wrong with your patient. Usually, if you feel like it's an emergency, usually we are going to immediately take control of that patient by just putting them on the bag valve mask yourself so that you know that they're getting air. And that's fine for the emergent case. But here's what we're checking for DOPE. Dislodgement, obstruction, pneumothorax, and we're checking our equipment, right? So that's DOPE, D-O-P-E. So the dislodgement, well, did that tube move? Because it can happen. And so we have to check every time. O, obstruction. Obstructions can happen because the patient bites or because we have mucus plugs. And so that mucus plug can be alleviated by jetting a small amount of saline and then sucking up that saline along with mucus from the ET tube using a sterile environment and a suction French catheter. Obstructions happen. Pneumothorax Collapsed lungs, also, these happen. So that's why we get our patient, we assess our patient before and during and after. And these are things that we want to understand. We want to touch our patient's thorax, right? So as part of that, if something is wrong with what's going on, and it's not a dislodged tube, it's not obstructed tube, then we're assessing for pneumothorax, that collapsed lung. And if it's not that, then we're checking our equipment. Do we have a ventilator failure? Is our battery dead? So that's what the equipment thing is. And I would say that if you can't fix the problem in 10 seconds, then we are disconnecting the ventilator and manually bagging that patient. We don't ever prioritize fixing the machine over oxygenating that patient. So these are all things that I hope will help you as you work with this particular piece of equipment. And it's a good review to make sure that we're all on the same page with the terminology. And I would say that the other part about ventilators is that patients are awake sometimes. And certainly if the patients aren't awake, their family members are. And so effective communication during these times is important. And for a lot of patients, the idea of being placed on a ventilator can be really scary or it can be really confusing. So as a paramedic, your ability to explain and to reassure and to coach the patient can make a really big difference in their experience and in their outcome. So I want to say that before initiating this ventilator, we take a time to connect with the patient, even in high stress situations, for a few seconds of clear, empathetic communication. And this is something that can calm the patient and improve their cooperation. This is something that allows you to acknowledge their feelings. I know it's hard to breathe right now. I know also that can feel scary, and we're going to help you get through this. So validating their emotions and explaining what's happening. Your lungs are working really hard right now, and we're going to use this machine to help take some pressure off of you and let your lungs heal while you breathe easier. And so once the patient understands that they need this ventilator, we also want to prepare them for that experience. And it's especially important for times that we're using CPAP and BiPAP. And we tell them this is a machine that will help you breathe by giving you steady, gentle breaths. It's like having a partner that's going to help your lungs rest and recover. We try to avoid using alarming kinds of terms like life support, because unless it's absolutely necessary, because we're there to keep the patient feeling good. And we set some expectations for how the patient's going to feel. So we might tell a patient, you might feel some pressure when the machine gives you a breath. And that's going to feel strange at first. This is normal. I'm going to be here to make sure that you're comfortable. So, we're preparing that patient for the physical sensations of the ventilation, especially if they're coming off one ventilator onto another, because it'll be a different machine in a different environment. And so we want to say things like, you're doing great. The machine's helping you breathe. Your oxygen levels are improving. These regular updates can help the patient who is scared actually feel cared for and reduce their anxiety. Because not all patients can be just automatically sedated every time. I have many critical patients who have such low blood pressures that we can't sedate them. And so imagine going through this nightmare. It's not a time to avoid the communication. It's okay to say things like, hey, if you feel uncomfortable or need anything, just signal to me, and I'm going to try to make you feel comfortable. And so these are all things that we think about when we think about this patient coaching. And in many cases, family members are going to be present and have concerns. And so it's okay to say, your loved one is having a lot of problems breathing, and so we're using a ventilator to just help support them.
This is going to give them a chance to recover and help the lungs heal. So we keep explanations simple and focused on positive outcomes. Now, I hope this training has been a good introduction to the use of a ventilator in the field. I liked being able to feature the ZVent made by Zoll today. And just know that our time together is not a substitute for hands-on training and experience. And I also want to encourage you to involve the support of respiratory therapists or your supervisor as you gain more experience with the equipment, because those are folks that are always willing and able to be helpful. All right, I wish you the best and good luck on your test. And I'm thankful again to be able to talk to you about ventilators today on behalf of City Ambulance Service Education Department and the First Responder Behavioral Health Institute. So, it's Bram Duffee signing off.